Disclosures for this and all episodes in this series can be found on the podcast series destination page located on education.webmd.com. The following presentation is copyrighted by WebMD Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of WebMD Education.
The following podcast is supported by an independent educational grant from CDC Foundation.
Hello, everyone, and welcome to our new podcast series titled Tools to Open Doors and Empower Patients, Strengthening the Clinician's Shared Decision-Making Toolbox, produced in partnership between CDC Foundation and Medscape Oncology. My name is Paulina Bravo. I'm an associate professor at the School of Nursing at the Pontificia Universidad Católica in Santiago, Chile, and I will be hosting our second episode entitled What Does the Evidence Say About Shared Decision-Making? A call to integrate the patient voice. So joining me today is Dr. Paul Barr, Associate Professor at the Dartmouth Institute for Health Policy and Clinical Practice. And I'm also delighted to introduce Dr. Sarah Friend, Assistant Professor at the Department of Hematology and Medical Oncology at Winship Cancer Institute for Emory University. So welcome, Paul and Sarah, and thank you very much for joining me today.
Oh, thanks for having me.
Yes, thanks for having me.
So, Paul, we have previously discussed in our previous podcast about the importance of communication in healthcare. And over the last decades, we have seen very interesting and increasing interest, actually, in how we can involve patients more actively in their healthcare. So, there is a specific term that has come up in many conferences and in many speeches around the world about shared decision making. And I think it would be great for our listeners today to know what are the goals of shared decision making.
Yeah, no, that's a great question, Paulina, and I think it's good to start with what is shared decision making, and you know there's three key elements to it. The first thing is just acknowledging that there's a decision to be made and that the patient is going to be part of that decision-making process. That's in the past not actually been really evident, where patients would go and expect their clinicians to make decisions or they didn't feel like they could contribute. And so really having folks aware, and we call this sometimes team talk. So that's the first part. The second part is communicating and understanding the best evidence around the treatment options or the healthcare issue that are being discussed at that time between the doctor and the patient. The clinicians are experts in medical information, and they bring all this knowledge to the consultation. But the patient brings all this expertise from their own lives and who they are and what their values are and what their goals are. And this is really important because most of the healthcare that we receive, we end up really managing it at home. And so we need to understand the person's values, goals, and what's important to them so that we can really match up the options with what's important to the patient. And it often happens when we have something called a preference-sensitive decision. So we're not too sure what option to take. Both are pretty effective. And really then it becomes very important that we understand what the patient's values are. And then finally, really, really and critically, once you've done that work, and it's hard work, you then want to incorporate those values of the patient into the decision. So it's not enough just to ask a person what's important to them. We got to really understand those values and those preferences, and then engage and integrate them into the decision-making process. And the goal overall is to really just help match the right treatments and right sort of decisions for that individual and their healthcare. So I think that's the real goal, and there's lots of benefits that we can talk about in a wee bit.
Thank you, Paul. Very interesting to hear about all the process and the components that you have described in terms of how to involve more actively patients in the medical decision process. And I was wondering, Sarah, from your experience, how do you see shared decision making within the clinical practice? What would you say be probably some of the obstacles that we might face when implementing shared decision making, particularly in cancer care?
Yeah, that's a great question, and I love that that definition of shared decision making. So I think when it comes to something like cancer, patients are going to come in with their preconceived biases about what cancer treatment may entail. They may know somebody who had a particular experience, and they themselves may feel that that they either would or would not consider something like the C word, chemotherapy. And so when a physician offers those treatment, it's really important to understand all of the preferences of a patient prior to just sort of imposing this what sounds to the patient like a toxic plan. So I think that for patients, understanding what is important to them, what's not. So things like, quality of life versus, um, wanting to try every possible thing, it is really important to have open dialogue with the providers. And I also want to acknowledge that with time, I think that patients' preferences may change. So, you may come in initially with your values and you may be afraid because you're told you have cancer and it's scary. But over time, you may say, well, you know what, maybe I will try this. Before I wasn't really wanting to think about that, but now I may try it. So I think that not being rigid and being open with your provider and your physician and having open dialogue is going to be really, really, really important. And so I think the shared decision making is going to go beyond the first visit.
Thank you, Sarah. And it's so good also to hear from your experience and how you see patients' preference might be ignored sometimes if we are not actively listening to them. Paul, I'm currently doing some field work in oncology care, and there is one quote that is coming to my mind in terms of one of the participants of our project sharing with us that going to cancer care is not as if you were going to the mall and you could choose whatever you want. So from your perspective, maybe you could tell us a little bit about what are the benefits of having this shared decision-making approach, but also what might be the main obstacles to implement it, or maybe some resistance as the one that I have just expressed. Yeah.
Yeah, well, I think the benefits really come down to when a person feels like their voice is being heard, and that is then integrated into decisions about care for them and their bodies, they're more likely to actually adhere to that care. They're more likely to have less decisional regret. Decisional regret's a terrible thing. You have a person, there's this famous story, I can just tell you it quickly, but it's two women, and the story goes that one of the women was diagnosed with cancer, with breast cancer, and she has a mastectomy. And then later they find out that she in fact didn't have cancer. There was a faulty reading, and she was really upset. And the health system reacted very strongly. There was a big investigation, and so there was a misdiagnosis. Now there was another woman. Let's call her Linda, and Linda, she had a diagnosis of breast cancer. She had a mastectomy, and that was all correct. It was, in fact, she had breast cancer, and in fact, she was able to have a mastectomy. She later found out from a friend that there was actually other options available to her. She didn't have to have a mastectomy. She could have had a lumpectomy or radiotherapy, or there's other strategies that Dr. Friend, being a clinician, could speak more about. But she didn't know about any of those, and she felt immense regret at her decision and was really sad that she had chosen the route of a mastectomy. There was no investigation done though, because the health system identified a cancer and removed it. It was successful. I don't think anyone would really, particularly for Linda in this case, would think that was a successful outcome for her, because that wasn't what she would have chosen had she been more informed. So I think there's an ethical imperative, but also actually we know from the literature that when folks are engaged in this decision-making process and their preferences are heard and integrated, not only are they more likely to adhere to the treatment, they feel greater satisfaction, they feel better understanding of what's happening to them in their bodies. And there's also some emerging evidence that it actually could improve health outcomes as well. One of the sort of there's several obstacles. I mean, one is around sort of lack of training in terms of how to do shared decision making, lack of comfort. And that leads into another thing that's important to think about is uncertainty. And we have a lot of uncertainty in medicine in general. Like, will this lead to a better outcome or not? We don't often communicate that because we're a little bit nervous. I think as our clinicians, particularly younger clinicians, feel like they don't want to sound like they don't know what they're talking about. But in fact, and Professor Paul Hahn, he's at the National Cancer Institute, he does a lot of work on how we manage uncertainty and being more open and transparent and communicating that we actually are uncertain about the path forward here and the results that we may have is a much better strategy than trying to hide that uncertainty. So there's lots of obstacles, but there's also lots of green shoots of hope and lots of really fantastic policy initiatives to push shared decision making forward. And I'm sure we'll talk about those in a little bit.
Yeah, absolutely. And I think you have mentioned something very relevant for cancer care. Well, it is actually relevant in healthcare in general. That's uncertainty, but specifically in cancer care, I think it takes a different meaning maybe in terms of expectation and what we can actually offer to people. So Sarah, from that perspective, how would you say that would be like an effective way to communicate with patients about risk and uncertainty within cancer care?
Yeah, I think that's a great question, and I also want to piggyback off of the example with the mastectomy versus lumpectomy, which is a really great example of shared decision making. I think that for the mastectomy example, what I think is important is questioning the physicians and asking why, and not feeling as though you're not able to ask those questions. So if a doctor explains the reason as to why they're recommending, maybe a more aggressive surgery, such as a mastectomy compared to a lumpectomy, if you don't understand why, then you're less likely to maybe want to proceed with the mastectomy. But if they explain to you, well, actually the margins, if you look at the volume loss from removing this very large tumor, we're not going to be able to fill the hole if it's just a lumpectomy, and it will be causing breast deformities, or we're worried about leaving tumor cells behind. So I think that, having, as a patient, asking the provider to, pull up the images, show me exactly the size, show me what you're describing and why you're recommending that. And I think that's so important to never, as a physician, you may think, of course, people know this, but they don't, right? This is their first experience with cancer many times. And so just reminding patients to always question their provider, and it's not offensive. It's something that we want you to do because we want you to understand why we are recommending this. And, that is just really important. And especially when it comes with cancer, you really want to do your best to offer the best treatment plan initially. I mean, the provider's goal in the cancer world is for the patient to not die of this cancer. But patients often take the view, at what cost? What is the deformity to my breast if I have this breast reconstruction? What is the toxicity of the chemotherapy? And so, it's ultimately going to be up to the patient as to whether they want to consider complying with the recommendation to take on a treatment that might, in their mind, seem very harsh. But using this idea of uncertainty and the fact that in everybody's minds, the physician included, we all think that this cancer, there's a small chance, even in some of the best cancers, that it can come back. So we really want to offer you the best plan now to prevent that from happening. And we can give you statistics based on, the data and the clinical trials, depending on your specific tumor type and stage, to tell you what the best plan is, at least, and what the standard of care is. But we know that even with our best treatments, there's still a small chance of treatment failure. And that's unfortunate. But if the cancer were to recur and patients decline the treatment, would there be any regret in their decision? And so I think for me, the shared decision making, I have patients that do decline my treatment plans, and I am okay with that as long as I'm 2000% sure that they understand and they really understand why I'm recommending what I'm recommending. And I think that's really, really important because for me as a provider, I have to make sure that she's fully understanding the choices that she's making. And it may be the right choice for her, right? Who am I to say? But I think the uncertainty around cancer is a huge part of how patients make their decision and why they do what they do. So,
Mhm.
yeah.
Yeah.
Yeah, and I
And I think,
just like listening. That's a really lovely description, Sarah. And you know, we have this case study that we teach in one of our classes, and it's looking at folks who live in rural communities, and it's a patient that just as you're describing, they're looking at the evidence, they're discussing with their clinician, and they decide that I've got this cancer, but I don't want the treatment. And of course, I think an important thing to know is that preferences can change. And so, like just as Sarah's described, which is wonderful, continue to meet with the patient. Maybe over the course of a few months, their preferences change and they decide to take the treatment, and that's okay. But the interesting thing in the case study that we have is that the person who declines the treatment, even though it could likely cure them, when we dig into it, it turns out that the patient had previously had cancer and had almost gone bankrupt because of the cost of care. And in their mind, they say, well, I'm an older adult, I have this cancer. If I go through treatment again, I could go bankrupt and I could leave my children with debt, and I don't want to do that. And so it gets to the importance of, it's not just about we're going to cure a patient. I think we all agree that that's really important, but we have to hear more about the patient's life and their story in order to make decisions about them and understand why they're maybe having these decisions that are a little bit different from what as a clinician you think would be the best course of action.
I think it's fantastic to hear both of you and how you so carefully choose the words that you use. For example, Sarah is talking about what I recommend to patients, it's my treatment recommendation for the patient, when usually we talk about plans and treatment per se, but not recommendations. So that also gives probably your patients the option to understand that there is actually something that they can choose. And also how you, Paul, are describing this not as a one-off action, but actually as a process that can be revisited, and also that people can change over time. So I wonder, what would you say, Sarah or Paul, were some of the best practices to ensure that we are, on the one hand, listening to our patients, but also to incorporate that into our care plan or care recommendation, and by doing that, how we promote patients' autonomy?
Yeah, I think there's a misconception that asking questions may offend the doctor, requesting a second opinion may offend the doctor. And from a physician perspective, I think we encourage it, and we want you to have a second opinion, especially if you feel like you need it. Because from our perspective, if you're not fully on board with this treatment plan, then you may be more at risk for non-compliance, and you just may not be as engaged in your healthcare and may not be as happy with the treatment decision you've made. So it's in our best interest as a physician to have you fully aware of the risks and benefits and fully on board. So when I have patients and I recommend chemotherapy and they're really not wanting it, I often encourage them to get a second opinion, because I want them to hear it from another perspective, and then they have a little bit more confidence and even a little bit more knowledge. Because if you can sit down with another doctor for a degree of time and just sort of ask questions, maybe that second visit is just what they needed. And often patients will still come back to me because they've gotten their second opinion, they've reinforced the plan, and now they're on board with it. So I always encourage it, and I think most physicians would be very comfortable facilitating a second opinion. I think this goes to the communication and patients being upfront with the physician about their preferences and what they're thinking. So I think that the doctor and the patient should to get the best care for the patient, they really need to be on the same page. And I do not think that physicians are threatened by that. They would prefer it because it will improve the trust in the relationship, I think.
Yeah, I think that, the integrating the patient voice, it starts at the top. A health system has to actually demonstrate its belief, its buy-in, its leadership, its provision of resources to support this. In order for the clinicians to be inspired, for the patients to know this is a health system that promotes my voice. And so a health system that's committed to actually being built around a patient. And Professor Victor Montori, who we both know very well, Paulina, his patient revolution and the work that they propose in terms of supporting and really promoting the careful and kind care back into the health system. At the individual level, I think we need to overcome some of these myths. And again, Professor Franz Legere has written about this quite a few years ago on the sort of the 12 myths of shared decision making. And some of these things are still pretty common. It's going to take way too long for us to ask patients their preferences and understand their values. And when you look at the literature and we look at reviews of literature, we see that it doesn't really add much time at all, maybe a minute or two. Or patients don't want to do it. They ask me to make the decision. And that's completely understandable. Folks are scared. They're coming into this system. They got this really emotional diagnosis and they're asking the doctor, like, what would you do? I'm sure Sarah probably hears that, every week, every day. And I think that the strategy there is, it's not about saying, okay, well, I'll tell you what to do. I think a skilled clinician will still elicit the person's preferences and help them decide on the plan that's best for them based on that sort of, based on really understanding the person. So I still think there's many opportunities to share the decision. It's helpful if we have some tools that could be used, and we have tools. We have these things that are patient decision aids, where we can outline the different options for a given, treat for a certain condition. And present the information that patients tell us are important to them in making decisions, and clinicians tell us are important that are communicated to the patient. And we can communicate information then on these different treatments, and we want to do it in a way that is at a really appropriate reading level, maybe 6th grade or 7th grade at the most, because health literacy is a real problem in all countries, really. So we want to make sure folks can understand the information. The use of visual aids, which are incredibly helpful for patients with lower health literacy. We want to communicate using frequencies. 5 out of 100 people will, have this side effect because of this treatment. That's a frequency, and people understand that much better than something like a relative frequency. 20% more people recover with this approach. It's hard for a person to really understand what that means. And I think finally, assisting our clinicians and our patients in training. Even with our clinicians, I think we need more standardized training in medical school from a really young age, really helping them understand what shared decision making is, how we engage patients, why it's important and valuable. And as a people, as a population, really helping children understand from a young age that they have a voice in healthcare. So I think we almost need to change how we at a very young level, how we talk with people, so that their understandings and expectations change as they interact with the health system.
Yeah, well, I think what you have said, it's so important because sometimes we might think that we can improvise with shared decision making, but actually this is something that we plan and we prepare for, right? From the health system level, but also, as Paul has described, clinicians might need a particular training to know how to elicit preferences, how to listen to this uncertainty that patients might also communicate to us, or what level of maybe even decisional conflict they might face when listening to the options. So Sarah has said something very interesting. We want patients to be fully aware and fully on board. And if we want that, we need to prepare, and we need to probably prepare patients and also prepare our health providers to reach this collaboration and to share the decision. It has been a pleasure for me to chat with you both today. I think you have shared very useful tips for our listeners today. So thank you very much for joining me today, and I hope we can meet up soon.
Oh, thanks so much, Paulina. It's been wonderful. Thank you, Sarah.
Yes, thank you both. This has been great, and I think it's a great conversation.